Hello, everyone. Welcome to our Facebook Live today. I'm Dr. Owusu-Akyaw from OrthoVirginia, one of our sports medicine fellowship trained specialists. I'm in Central Virginia at our Shredder Road office in Richmond, and one of our leading hip arthroscopists, doing a lot of hip arthroscopy for people in the community. So I've been at OrthoVirginia about 3 years. Before that, I was in New York at the Hospital for Special Surgery. And before that, I was at Duke. So I've been East Coast for quite some time, although I grew up in Texas for the most part. So today I'm going to be talking to you about hip arthroscopy, what I want you to know about it, what's new in it, and what it can do, what it's about. So we throw the term hip arthroscopy, or really arthroscopy in general, around pretty frequently in orthopedics. And even if you're watching like ESPN or something, you'll probably see the term like, oh, so-and-so got a scope, got a knee scope, or got a shoulder scope. And we just talk about it like it's, something everybody knows about, but I thought it might be nice to break it down for someone who's less familiar. So arthroscopy is using basically a small camera to look inside of a joint and to do work within it. So that allows us to do minimally invasive surgery. So I actually have a sample of an arthroscope here for you all to see. So this is what the camera looks like when we do an arthroscopic surgery, a scope, we call it, okay? And so it has a few different parts. So this part back here is the actual camera. And when we're doing surgery, we're actually using this to watch a screen and perform the surgery. It's like a video game almost, okay? Attached to the scope is a lens, and that lens kind of allows us to change our view, almost like a periscope on like a submarine. So it's like you're looking up and around the corner. So I can take this little handle here and turn it side to side, and I'm looking up and around inside the joint all around to do what we need to do. And now this is just a sample, but there's also a light cord that runs up into the camera here. This cord is that light cord. And it basically shines a light through the camera so I can see inside. Now, when we're doing an arthroscopy, we have to make the joint big enough for us to be able to work safely. And to do that, we fill the joint with fluid, with saline or salt water. It makes the joint big enough for us to do our work. So a lot of patients will ask me, well, why is my joint so swollen after surgery? That's because we get it filled up with water so we can put our camera inside. So arthroscopy, scope, we can use those interchangeably, and we will. But I want to give you all some background knowledge. Before we get started, we went in there. We went to Google to find out what your top questions might be. And so these are the top 3 hip scope Google searches in Virginia. All right, let's go to the first one. Okay, if everyone can read that. How successful is hip arthroscopy? Okay, so success depends on how you define it. So for different people, that means a different thing. So we'll go into the details of what a hip arthroscopy is soon, but for some people, their goal is simply to be without pain and to be able to sit and, just kind of live life and kind of take walks with the dog, with the family. For that certain population, the success rate is something like 85 to 90%. All right, very successful surgery. So in terms of doing day-to-day activities, hip arthroscopy is very, very successful. If your goal is to do something a little bit higher impact, right, playing sports, competitive sports and that kind of thing, a lot of people will have a very good outcome with that, and they'll still have excellent results with pain. However, after a big surgery like that, going back to playing sport like you did before is a little more difficult, okay? So that rate can be something more like 70% of people will go back to play like they played before the injury. Now, that being said, not all those people don't play because they can't. Some people choose not to play. They say, I don't want to play that sport anymore. I'm worried about getting injured. So it does vary based on what you define success as. But as far as orthopedic surgeries go, a 90% success rate is excellent to us. That's still an A. That is an A to us. So hip arthroscopy is successful surgery. All right, let's go to the next slide. How long is the recovery after hip arthroscopy, after a hip scope? Okay, so again, that is defined by what you call a recovery. Now, for most people, they're going to be on crutches for some aspect of a few weeks after hip arthroscopy. They may or may not be wearing a brace after surgery, depending on what's done and how much they need done for them. Usually around, 8 to 10 weeks, people are able to walk around, do more daily stuff on a regular basis, okay, for most patients. Now, we get to people doing something more like running and that kind of thing, more impact activity around 3 months after surgery. And then the return to sport, on average, if one plays a sport, competitive sport, usually on the order of 6 to 8 months. Okay. It may take some patients up to 10 to 12 months to get the full benefit, or even longer in some cases, depending on their individual circumstances. So again, recovery depends on who you are and what your goals are. But that's kind of the basic timeline for hips goals. All right, and number three, Google search. What complications can occur after hip arthroscopy? Complications are something we have to talk about with surgery because the risk is always there anytime you do a surgery. That being said, hip scopes are extremely safe and the complication is quite low, on the order of 6% according to some studies for all people who have them. The things that can happen. So with any surgery, infection is always a risk. So we always take every precaution necessary for that. Blood clots are always a risk as well. We usually have you on some kind of a blood thinner, be it an aspirin or something like that, to keep your blood thin to prevent blood clots from happening. Because I understand those are scary, and they're scary to us too. Some people can have nerve irritation. So when we're doing a hip arthroscopy, we do have to kind of pull on the hip joint to pull it out of socket slightly, just to get inside so we can put the camera in. That process can cause irritation of some of the nerves around the hip. Usually that goes away and it just feels like a little bit of decreased feeling, like on the side of the thigh for most people. Usually it's gone by a few weeks or you stop realizing it, stop worrying about it. And then some people will have, unfortunately, a re-tear of the labrum if we're fixing that. And I'll show you some pictures of videos of that soon. If you had that happen to you, it's possible to have surgery again, which is a complication. That's on the order of 6 to 8% of people might have to have surgery again after a hip scope. But again, everybody's circumstances are different. So those are the top 3 Google searches for the state of Virginia about hip arthroscopy. So we're off to a good start. If we can pull up the slides, we'll show you a few more things. All right, so again, talking about advancements in arthroscopic hip surgery. So back to that second question about how long the recovery is. This is a basic timeline that I give every patient before surgery so they can kind of understand, the map of where we're going. And I like to break recovery up into phases. So here you see phase 1 through 5. Right after surgery, in the first phase, your physical therapy, probably about once a week, just working on gradually restoring your hip motion, getting your hip to move again, remembering how to fire the muscles around your hip, the glute muscles, the core muscles. It starts out pretty simple. Weeks 2 through 6 is phase 2, and that's where our goal is to get you to walking more normally. So you would start off with crutches in phase 1. In phase 2, as you get more and more comfortable, you start losing the crutches. So for a lot of patients, that looks like losing one crutch and then using one crutch for a while and then going to no crutch. All this time, your physical therapist is watching you like a hawk to make sure you're walking properly, not developing limps or bad habits with how you're walking. We don't want you developing limps that'll hurt you later on in the recovery. In phase 3, week 6 on to 12, we're working on more strengthening. So that's when PT, as I tell patients, that's when things get fun. All right, so that's when you're getting in. It feels more like a workout. You're doing leg press, knee extensions, getting some core work in again, squats. All that starts to happen in phase 3. We're not running or anything like that. Everything's still, flat on the ground. But we're getting you to do some more strengthening. It gets a little more exciting. Phase 4 is when we start doing that running. All right. We gradually introduce running with a good form, once again, with the therapist watching you, increasing your impact activity. The goal of the previous phase was to get your muscles strong enough to protect your hip for when you add impact. So now that we've reached that goal, we're going to work on that impact together. Gradually running, gradually introducing things that are related to your sport. So for instance, if you played soccer, this would be a time when you would start introducing some real light drills, all right? Dribbling drills, kicking the ball back and forth, agility ladders, that kind of stuff is integrated during phase 4. We build up and we build up and we build up until we get to phase 5. And that's where things become kind of choose your own adventure. So it depends on what your goals are. If you're going to play competitive sports, then phase 5 is where we start talking about testing your strength to see if you're ready to play sports again. And if you pass those tests, then we start looking at getting back into practice. Starting off low impact, low contact practice. So like a football player would start off playing no contact practice, okay? We're running routes, getting back used into the muscle memory of their sport. And then once they master that, doing some scrimmage work just with the team, right? And then once that feels completely normal, then we're getting back to playing in actual games. But even then, we always remember return to sport is not a moment in time, it's a process. So even when you're quote unquote cleared for sport, you're not jumping back into a whole game. You're going to do load management. You're going to play for part of a quarter, right, to begin with. And then as that gets better, play for a half. Always monitoring your symptoms and seeing how you're doing. Because this is a serious injury. You want to make sure that you fully recover before you go all the way back. We can go next slide. All right. So the main reason to do a hip scope are two: either to fix a labrum and or to deal with hip impingement. So what is the hip labrum? Well, if we think of the hip as a ball and socket like this picture kind of shows, you can see that the articulation here is surrounded by this yellow kind of suction cup called the labrum. That suction cup is meant to hold the hip joint kind of solid. And when it gets torn, like this red line here indicates, you can develop what's called micro instability, wherein the hip doesn't quite stay as stable as it should. And that feels like pain to most people. Frequently, it feels like pain in the groin. So a lot of times this will be mistaken for like a groin pull or your adductor strain or a sports hernia or even hip flexor tendonitis, which can also happen at the same time. But frequently, we need to start thinking about labral tears if someone is having pain in the groin, because it could be that. So on the right side of the picture, we have an actual picture from me doing surgery, and that's an arthroscopic picture of me looking at the socket with the labrum going around. And so that metal kind of rod you see up top, that's me pushing on the labrum, showing how it's separated from the bone underneath here. We go into the next slide. So one of the main things we're doing when we're doing surgery is going in and fixing that labrum, like I said. So on the left, you see the cartoon shows how I passed stitches up and around the labrum, and I anchored it back into the bone. We do that using, we call them suture anchors, but really they're like tiny plastic screws. And they actually go into drill holes on the socket or the acetabulum that holds that labrum in place until it can heal. Now, an important thing to remember is that our stitches are man-made, and it's only so much that we can do. The body has to heal itself. So our goal is to put it back in place and try and stimulate healing at that site, not just to stitch it back. So the picture on the right is that same image from before after I fixed it. So I put those stitches around the labrum, like you see, they're kind of white and purple there and striped, and they're anchored back into the bone back behind it using those tiny suture anchors or plastic screws, if you like. We go to the next slide. So here's a video kind of showing you in real time the process of doing that. So right now we have the labrum there, and I have what's called a suture passer, kind of a sharp hook that helps me push that stitch to go around the labrum. So here I am putting it around it. So first I put it through, then I bring my instrument back out and around. I go back and grab it, and now I have it going all the way around the labrum. And that's how we start with just one stitch, and we just do that multiple times. We go to the next slide. Here we go. Okay. So now you can see the kind of metal instrument up top. That's me in the process of drilling a hole into the bone of the socket or the acetabulum, where the anchor is going to go, the plastic screw. In a second, you see it's going to give you a change in angulation. You can kind of see the drill going. And there you go. So you see the drill is kind of spinning in its guide, and that's actually drilling through the bone. So when we're doing that, we're checking the cartilage of the joint very closely to make sure our drill is not somehow interfering or hurting the cartilage. So we watch it very closely under the arthroscope. So we go on to the next slide. Great. So then we take those stitches or the suture that we put around the labrum and put it into this anchor. And so the anchor is kind of inserted via that little metal tube you see up to the top left. And then as it gets closer, you'll be able to see that we're going to slowly and gradually advance to the anchor. And that's going to help knock that stitch into place. You see how it's slowly tightening over the labrum. So what you can't see is outside of the joint, I'm actually using a mallet or a small hammer to put that anchor down. Now you see it advancing, going into the bone, nice and solid. Once I've done that, I can kind of tension or pull on the stitches to get them exactly how tight I want them to be for the circumstances. So that's about to happen here in just a second. So here I am pulling on stitches, and you see that labrum sucking down right back to the bone. And that's exactly what we want to see. So that's one stitch of a labral repair. We go on to the next slide. So in this case, we put two stitches side by side, and then here we are, having fixed that labrum back to the bone. Good. All right, we go to the next slide. All right, so we talked about labral repairs. Another reason to do a hip scope is to treat something called hip impingement. And what that is when some people will have almost an extra bit of bone next to the ball that makes their ball look more like a square peg in a round socket. So it tends to hit the socket rather than going through smoothly. So our cartoon on the left shows you a hip ball and socket, of course, like we saw before. And that kind of red overgrowth area of bone there kind of looks like a big bump. And that bump, as you might imagine, if you're moving your hip around, would tend to hit the socket. And that labrum, that suction cup, is right there in between them and can be torn or injured. So can the cartilage of the joint itself. So it's pretty common to have impingement and a labral tear go together. They usually go hand in hand. So the picture on the right is an example of how we smoothed out the bone for a patient who had an impingement and a labral tear. So the top right shows before we did our work, and you can see that large bump right next to the ball. Then look down to the bottom right, and you can see how we smooth that out. Now we have a nice smooth contour there, and that's not gonna bump when he moves his hip around, and he can get back to playing his sport. All right, next slide, I'll show you some videos of what that looks like in real time. So when we're doing this, it's literally us taking what looks like almost like something used to sandpaper something, and we just grind it down. So that's me in the process of just going around and smoothing out the bone, grinding it down. And it's really meticulous work, and we check x-rays while we're doing surgery to make sure we're doing it properly. Let's check it one more, let's watch that one more time. That was a Hollywood shot. So here we are, just smoothing out that bone nice and systematically, okay? And it takes nice, smooth movement, good control, good visualization to make sure we can see what we're doing. All right, we can go to the next slide. And here we are having completed our smoothing, and we're moving the hip around, and we're making sure that nothing's catching on the labrum. The labrum is on your top right in this picture. So you can see it up there. One of my stitches is kind of in the view. You see how nothing's catching on it? It's going nice and smoothly. That's how we know we've done the appropriate task. We've done what we needed to do. We've taken enough bone, and that we're gonna be okay. We can watch it one more time. So once again, we're looking at the spot where we smooth out the bone. We're looking at how the hip moves nice and smoothly. The labrum's not being impinged, it's not being injured when we move the hip up in flexion. And as we move it around, you see that you have a nice suction cup seal on the hip joint. It's staying in place. And it's exactly what we want to see at the end. All right, next slide. So frequently, when we're working on a hip joint, we have to open what's called the hip capsule. Now, every joint in your body, hip, knee, elbow, shoulder, has something called a capsule around it. It's almost like a saran wrap that holds the whole thing in place. Now, for the hip joint in particular, it's it is the thickest hip capsule or joint capsule of any joint. And that's because it's one of the strongest joints in your body, as you well know. So we frequently have to open up the hip capsule really intentionally compared to other joints because it's so thick for us to be able to get in to do our work. Now, increasingly, we've learned with time that it's very important that we make the effort to then suture or stitch that capsule back together. And we found that patients do better. They have better outcomes, better return to sport, better pain control, if you take that extra step to close that capsule over the top of the hip joint. So if we're looking left to right on this image, on the left, we see an example of a hip joint where that saran wrap around the joint, the hip capsule has been opened, okay? And so the middle slide shows how we've passed some stitches on both sides of that. And then on the right, you can see where we tied that down and now we've closed that hip capsule up. And so I'll show you an example of what that looks like on the next slide. All right, so we're looking inside the hip joint. What's happened here, and we'll run it back one more time. You can see where we had stitches in, and we passed them on both sides of the cut of the capsule, and we pull it down tight, and then we tie it down. On the next slide, you'll see how we tie it down with ring. So now we have another suture or stitch. This one's green. And so we passed them on both sides of the capsule cut. And now we use what's called an arthroscopic knot pusher. It lets us to tie knots on the outside of the body. And we can use this little pusher you'll see in a second. It's almost like a metal rod to push that knot down into the joint. So here comes my knot. And what you'll see soon is I'm gonna push down this metal rod to help push that down into place. There it is. So I'm pushing my knot down. Now that's gonna hold nice and tight. And just like I'm a Boy Scout, I'm throwing knots in multiple different directions, okay? And each time pushing it down hard with that metal tube. We'll watch it one more time. So that green stitch is on both sides of the cut, all right? And so we put a knot onto there and we let it slide down into the joint. So it should come in here momentarily. Here it comes, there it is. The knot comes down, and then my metal knot pusher is coming in. I'm gonna push that knot down and secure that capsule closure. All right, and that usually takes anywhere from 3 to 5, or sometimes 6 or 7 stitches, depending on the situation, on how big we have to open the capsule or how much the patient needs. I think that's it for the slides. We have any more? That's it. Okay, so we had one more. That's all right. That wasn't very important. But at any rate, so that's what I wanted to tell you formally about hip arthroscopy. It's an emerging and growing aspect of sports medicine. It's probably the fastest growing part of sports medicine. There are a lot of patients that we can now treat and help who we didn't necessarily know that we could treat before. And we've got emergent techniques that are making it better and easier for patients to get back to the things they love if they have issues like hip impingement or hip labral tear. Now, I understand there's some questions we might be able to answer here, so I'm happy to take them.
Thank you so much. Yes, we do have some questions. Our first question is someone who had a femur fracture and has some rods and nails and so on in her leg. Are you able to have arthroscopic procedures after you've had fractures like that?
That's an excellent question. It depends on the situation, specifically what type of rods or what type of metal implants you may have. In some cases, yes, it can be done. In other cases, depending on what was done, it might not be. So I would certainly recommend, talking with your doctor who performed the surgery to see what type of implant you have. And in that setting, it might be a possibility that an arthroscopic procedure could be done.
Is this procedure something that people can get while they're waiting to get a hip replacement for arthritis?
That's a great question. So if somebody has arthritis, we're saying that the cartilage in between the ball and socket of the articulation has worn away. Okay. And we grade arthritis basically on a scale of 0 to 3. Okay. So a grade 3 is when you're bone on bone. There's no space in between, the cartilage is gone. And that is when most people get a hip replacement. Okay. Someone who is grade 2 or 3 will tend to not do very well with hip arthroscopy. The reason for that is that even if we fix the labrum or even smooth out the cartilage, we can't put the cartilage back. Once it's gone, it tends to be gone. And so those patients tend to not have very good pain relief. Now, someone who has a little bit of arthritis, like a grade 1, or ideally no arthritis, like a grade 0, will likely see more benefit from a hip arthroscopy. And some studies have shown that people with grade 1 hip arthritis can do well with a scope, but would take longer to recover than someone who had no arthritis at all. So to answer your question, this is something that can be helpful for someone who is not ready for a hip replacement if they meet the proper criteria, if it's the right surgery for them. But it's not something that if it's time for a hip replacement, that this would necessarily stop you from happening.
I have a couple of people asking if there's a BMI limit for this procedure.
Not specifically. No, there is a recent study that came out saying that patients with a BMI over, I believe, 35 or 40 would have a longer recovery than patients with a lower BMI. Now, that study did show that those patients in the end ended up doing just as well as the patients with lower BMI. However, it took them longer, sometimes a year or longer, to get to the same place that the other patients got to. So the answer to that question is no, there's no strict BMI cutoff. However, it is a consideration to think about how it might affect the recovery after surgery. And in some cases, it might make sense, depending on how you and your doctor talk about things, to look at potentially ways to optimize your BMI before going into surgery to make sure you have the best possible outcome.
Do labral tears always need surgery, or can they also heal on their own?
That's an excellent question. Labral tears do not always need surgery. The majority of people with labral tears do not need surgery. People who end up undergoing surgery for a labral tear or hip impingement are those who have tried everything else first. So the majority of people will get by strengthening those muscles around the gluteus and around the hip joint and the core, and allowing that to act as a stabilizer to the hip joint. And that's probably 7 to 8 out of 10 people will feel better, even if they have hip impingement and a labral tear. It's only the minority of people who don't get better with those options for at least 2 to 3 months of trying that we do surgery on.
Is there an age restriction for this surgery?
There is no strict age restriction. Now, people over the age of 60 tend to have, in most cases, tend to have arthritis in their hip if they're having hip pain. That's how it usually goes. And so from that standpoint, it tends to not be a surgery performed on people over the age of 60. Now, that being said, age is a number, and it's more about function and how much arthritis you have or don't have. So the typical age range for the surgery is between the age of 16 to 50, all right? But everything is based on your personal circumstances and your personal goals.
If someone has had a hip injection for a labral tear and it's worn off and they're having pain, do they get another injection or do they have surgery?
Well, that's a great question. That very much depends on your personal circumstances and goals. So if you had a successful injection for a labral tear of the hip joint, that's great. And that's a great way to hold off on going into surgery and give you some pain relief without having to undergo a procedure. What we may warn you of is that repeated injections of, say, like a steroid injection into the hip joint for someone who does not have arthritis may not be the best thing for their cartilage. So it's not necessarily that one needs to go into surgery after getting said injection one time, but I will really, really talk to your doctor and consider the options, understanding that repeated cortisone injections are not very good for your cartilage.
Are there any special considerations that someone who has Ehlers-Danlos syndrome or hypermobility should take when considering this procedure?
Absolutely. So people with hypermobility have a higher tendency or increased rate of microinstability of the hip joint. In some cases, they'll have like true instability, like their hip is actually popping out of place. In that case, if the hip is actually popping out of place, an arthroscopic surgery may not be the best route for them. Now, for someone who's having more microinstability, more like pain and like it feels like catching almost in the front part of your hip around the groin, hip arthroscopy can be very successful for those patients. Now, the special consideration in that setting is about management of the capsule. So that capsule we talked about, that saran wrap going around the hip joint, is critical for patients with hypermobility. And so it is very important that when entering, we're very careful about how we enter that hip capsule and that we're very meticulous about closing it at the end. And in some cases, we'll even tighten it up to make it a little tighter than it was to help decrease that instability of the hip joint. But for patients in that situation, adequate capsular management is absolutely crucial, very important.
Is there anything that a patient can do ahead of surgery to improve results and recovery?
Yes, I'm a big fan of what we call prehab or rehabilitation before surgery. And so you want to make sure those same muscle groups that we're going to be working on so hard after surgery are ready to go beforehand. So what are those muscle groups? So that's your gluteus, and that includes your gluteus maximus, medius, and minimus. So just to take a quick second to talk about the gluteus. So a lot of patients will tell me my gluteus is strong, I do a lot of squats, and that's excellent. But that's more so working your gluteus maximus, and that's good, but we also need the medius and the minimus in the game. So to get to those, you're looking at more like abduction activities, and that's the machine I usually see empty at the gym because no one wants to mess with it. But it's actually the most important thing for this situation. So that's almost like sitting and opening up your legs side to side or lying on your side and lifting your leg up to the ceiling. And that's hip abduction, very important. And then core. I can't say it enough. So that's planks, sit-ups, whatever it takes to get to your core musculature. It's very important to make sure that's optimized before going into surgery, if it's possible for you.
A question about repair versus reconstruction. So if the doctor is in your joint doing this surgery and sees a lot of extra large damage to the labrum, what do they do in that case?
That's a good question. That's very much a case-by-case basis. And it would depend on what you and your doctor had discussed beforehand. So there are some situations where we are expecting to see a lot of damage that's unrepairable in a labrum, in which case we may consider talking to you about doing what's called a labral reconstruction. And that means taking tissue from elsewhere, either your body or from a donor, and using that to rebuild a labrum. So labral reconstruction is a pretty extensive procedure, and it changes the rehab considerably. So that's something that either we would have wanted to talk about beforehand as a possibility to prepare for that, or if it turns out we were expecting a repair, but got in there and it was extensively damaged, we would likely perform what we had talked about or the best we can, and then have to talk about it afterwards and see how things went from there. But it's all about how you and your physician have talked about it before surgery, so there are no surprises at the time.
What are things to consider when choosing a surgeon? Do you use a post in surgery?
I never use a post in surgery. I use postless arthroscopy. And just to review that for everyone to understand. So when we're doing hip arthroscopy, we have to, like I said, pull the hip slightly out of socket to get inside. In the past, we have done that, or many have done that, and some still do, by putting what's called a post, or almost like a rod in between the legs, and pulling the leg against that rod. So that's called the hip post, okay? And so recently, in the last few years, we've developed some techniques that allow us to perform that same opening of the hip joint without using that post. And many of us have found that has decreased injury to the groin because there's no post in the groin, decreased muscle injury, and increased or made a faster recovery after surgery, many studies have shown. So me personally, I do not use a post. I use a postless system. I've had great outcomes with patients for that. Now, when choosing a surgeon and when thinking about it, you want to take a look at things like their experience with performing these surgeries. Do they have specialty training in this? So many of us will do what's called a fellowship after our residency in sports medicine or arthroscopic surgery, at which time many of us will do a lot of hip arthroscopy. You could ask questions like, what is your technique for capsular management? What is your rationale about repairing the labrum? But I think the key is one to make sure it's someone who's experienced, who has done proper training in this, and is willing to sit down and talk to you and make you feel comfortable with the plan of care is.
Which diagnostics are performed to diagnose tears versus arthritis?
Good question. So the first diagnostic that's used in this situation is an X-ray. So an X-ray really shows the bone and the bone alignment, the joint alignment. So an X-ray does not directly show us cartilage, but what it will show us is how much space is there in between the joint, okay? And we can use that as a proxy to tell us, hey, this is an arthritic hip, or maybe it has a little arthritis. So I can easily see when a hip is bone on an X-ray. Now, when someone has maybe a little bit of cartilage wear, that's harder to see, and I certainly cannot see a labrum on an X-ray. So an MRI is the diagnostic option of choice to fully diagnose, say, a labral tear. An MRI will also show the cartilage within the joint a little more clearly than an X-ray, more directly, and so we can get a better sense of how much cartilage is there. So an MRI combination with an X-ray is the usual diagnostic standard.
Right. Thank you so much, Dr. Owusu-Akyaw. That is all the time that we have for today. If you answered a question during the Facebook Live that we did not have a chance to get to, we will answer you in the comments later. Dr. Owusu-Akyaw, would you like to close?
Yeah, it's been my pleasure to talk to you about advancements in hip arthroscopy. We've increasingly found ways to help patients with all kinds of different hip issues. And we're excited to see what is on the horizon for this increasingly important field. So everyone learns something from us, and have a good one.